Okay. We have roving mics right behind you. So let's go ahead and take the first question here. And I'm going to try and repeat the question for our video streaming folks.
Hi, this is Khalid Das. I'm one of the 1,200 pediatricians trained at CHLA for residency.
Great.
This is a question specifically for Mr. Viviano. The question I have is, yes, there are incredible financial pressures to run a place like Children's Hospital. Where do you foresee Children's Hospital for the near term and the long term as one of the premier referral centers for the Pacific Rim countries, which are the emerging economies, which might be able to alleviate some of the pressures? There are some established health systems, like in countries like South Korea, maybe Singapore, Taiwan. So I'm just curious to know, where do you see yourself? How does CHLA position itself for referral base from the emerging economies and the Pacific Rim countries?
So that's a great question.
Can I just repeat it for the video first?
Sure.
Let me just repeat the question. And one of our pediatric graduates from residency program at CHLA asked, how can CHLA specifically position itself to take care of the needs coming out of the emerging Pacific Rim countries right now?
So thank you for the question. We do have a modest international program. We get about 400 patients a year internationally mostly from Pacific Rim countries and from the Middle East. And so it is something we're working on expanding. Those patients typically have very, very significant clinical needs with a lot of family support. And so we're looking at enhancing those programs, transportation, local housing, post-care transition back home. And so it's something we'd like to build on. It is a way to help improve our financial circumstances. Typically, strong reimbursement accompanies those patients. So it is one of many strategies that we're trying to leverage to help expand our footprint and to bring more financial stability to the organization. Thank you.
Yes.
Hi, Richard Singerman. My question is really across the board, and that is, for the care outside the hospital or doctor's offices, we try to prevent these multiple ER visits. How many social workers, community health care workers do you have in absolute numbers, and also what's the relative ratio, and how do they interact with, often there's the issue of people think family caregivers with the elderly. Of course, you have the mirror image with pediatrics. So how is that interplay in extending care outside of the walls of the traditional healthcare system going? What are opportunities maybe for improvement?
And Richard Singerman just asked a question and essentially asking how many case managers are assigned, if I get...
Case manager, the whole spectrum of
community health workers, social workers.
Interaction with family caregivers, a parent or maybe a relative. Like, how is that being supported right now, and how can that maybe be enhanced to take some of the pressure off inside the walls of the hospital?
So I'll take a swing at it just for Children's Hospital Los Angeles, and I'm sure Mike has a much more scholarly view of 12 different states. So just for CHLA, I mean, it's a complex situation, and we've talked a lot in all three of these presentations about the social needs, and the social needs, the fastest growing part of the needs of our delivery care system today. And so what used to be a routine problem that was just treated clinically, now because of the social determinants that Mike outlined, there's a big infrastructure that's required. So today we see we average about 350 inpatients a day. We see about 400 patients in our emergency department. We see about 500 patients a day in our primary care clinics on campus. And so that translates, we have about 250 social workers, a very significant team and infrastructure of caregivers that have transitioned into helping us with transitions of care and other support infrastructure. So it's a big commitment, but the social needs are very big, and we haven't invested enough, and we need to invest more going forward. But it is something that's on our mind, and it's an investment that we make. in terms of interfacing with the families, and that is the point of all of it. And the social determinants that Mike outlined really impact the care of these children in a really material way. So we try to help with their transition back home when we can.
Yeah, I agree with you, Paul. I think as important as the care is when people are in the hospital, if you don't focus on what they're going home to, then the chances of them ending up back in the hospital would be much greater. And in fact, I kid when I go home and people ask me, what do? I say, well, I run a social service agency. Because basically, care in this country is pretty good. And when someone goes in the hospital and they're really sick, I think everyone there is to do the best job they can. But when they go home and they don't know how to make a follow-up appointment, they haven't filled their prescription, they haven't followed through with the instructions they've been given, then the chances of them coming back in are greater. So there's a program that actually has been developed by a Dr. Coleman in Colorado. It's called the Transition to Care Program, and some of you may be aware of it. And it's where when someone is in the hospital and they're getting ready to go home, a nurse comes in and goes through with them, what's going on with you, what your needs are going to be when you're home, making an appointment, taking your medication. When that person goes home, they then go to the home and see that person within the first 24 to 48 hours. I mean, this period of transitioning from hospital to home is critical. I can only tell you when I was a patient here at UCLA for just one day, minor procedure, I walked home with 2 different sets of discharge instructions. Now, I knew what to do, but, it can be very confusing. And I think most people, if any of you have been in the room and in the hospital and you go to your doctor and he tells you to do this and that, and you go home, it may not be quite as clear what he or she said. And I think it is even more so for the disadvantaged populations that we work with.
I just wanted to add one thing real quickly. There's some work being done both at UCSF Benioff Children's Hospital Oakland by Dr. Dana Long, and some work that's been done by, I think, Paul Dworkin at the University of Connecticut Children's Hospital around really trying to figure out, there's this whole field of study around social determinants of health, but how hospitals can get beyond their 4 walls and really going out into the community and looking at, is there lead paint in that child's home, and how do you really address that? And so there is, there's sort of a body of work being built up, and particularly Dr. Dworkin's work, I think, has been replicated in a number of communities, and trying to figure out sort of what's the best way to really go and interact with families in the community to make sure that you're not getting that same asthmatic kid coming back time after time because there's something going wrong in their house, So I can get you more information on that if you're not familiar with it, because we've done a little bit of work on. We're aware of some of that work that's going on.
Bill Kaufman, as a pediatrician who now spends almost all of my time working with the elderly, I have a sort of public policy question. The elderly are not the enemy of the young children. They're actually the same. Young children are on their way up, the old people are on their way down. The needs are almost identical across every domain you can think of. The difference is children have one chronic condition, adults have multiple. But it seems to me that from a children's hospital perspective, or health plan's perspective, policy, how do we make it so that the things that we do for seniors, as well as the grandparents who care about the children, contribute to the capacity of making the children's services be better? Because they really do need the same infrastructure. And they've not been created in such a way that they can be successful. So how do we use the children's oriented people, the policy people, advocacy people, and the seniors and get them together?
Okay, if I could summarize.
This is the last part of the question.
Well, Neil Kaufman, I do know that, but as a pediatrician, he's actually working with elderly now. How can we use the experience and understanding and treating of the elderly population as they are on their declining time, whereas kids are on their up and coming time, how can we use that experience and knowledge from that in the pediatric world and help with the pediatric, and how are the policymakers going to incorporate that into their planning, financing, et cetera, for pediatrics?
So much better than that.
Well, I would say as somebody who works in Sacramento, there's a fair amount of interaction that goes on at the policymaking level around trying to look at where are the high cost folks, and trying to figure out if we can kind of use the same kind of approaches. So, for example, the state looks at they're looking at a home health waiver to see if there's more stuff that we can do to keep people at home. And they're looking more at conditions rather than at age groups. So they're looking at people with multiple chronic conditions, for example. So I think we're trying to break down those silos at the policymaking level. I can't speak to it as much, maybe you can, or one of my two other co-panelists can, at the more provider level. I do think there's a danger sometimes for constituencies to argue with each other about who is more deserving, and that can kind of get in the way of a more holistic approach. But I would give the state of California credit, the Department of Healthcare Services and the agency, the Health and Human Services Agency, for really trying to look at both. They've got something going on around whole person care, they've got something going on around home health, and even in their approach to sort of trying to do managed care, that they're trying to look at it more at the level of the commonalities around the complexity of taking care of people with multiple conditions or people who have particular demands that go beyond just the medical silo in terms of psychosocial and other social supports. And that's a big focus of energy within the healthcare agency itself.
So from an advocacy perspective, obviously, so this is something that's really meaningful and on our minds from an economic standpoint. I'll repeat a couple numbers that may not be precisely accurate on a statewide basis, but directionally they're close. And so the average Medicare admission to a hospital generates about 7 times the revenue than an average pediatric admission does. And when you translate that, if you flow that through your profit and loss statement, as you take care of all the costs, the bottom line impact is probably 7 times greater than that. So 50 times greater the profitability to a hospital to take care of a Medicare patient. So the advocacy efforts of the national hospital associations, et cetera, chase the big money because that's going to be the most enriching to the provider community. And so we're kind of left out of that. How do we have a stronger voice to advocate for what you've identified is a real need, something that Anne and all of us spend time as part of children's hospital associations trying to figure out how to lobby for this deserving population to kind of bring it back into parity. And it's a great question and something we really wrestle with. I don't know if you guys focus in that way or not.
Well, I'm not a finance person, so it's going to be hard for me to respond in that way. But let me tell you what I've learned, because, Neil, just like you, right now, I work with a program that's what's called the dual. So it's people who have both Medicare and Medicaid, and it's a much older population, but it also is one that has many more needs. And what I've learned for both that population as well as children with special needs, that having a coordinated care support system around you can help improve your care and outcomes. And I think that in part will go to not only improving the outcomes, but decreasing the cost. And I think that brain tumor case I reviewed is an example of that. I know that with our own internal analysis of the high-risk OB program by preventing premature deliveries and also the program around neonates, we were able to see a decrease in costs for these areas of care. So I think if you do the right thing and you focus on the right areas, and again, in a coordinated care manner, you'll you'll basically advance the issues around cost and quality and outcomes.
I'd like to commend all the panelists for a great discussion. My name is Jessie Shawada, pediatric infectious disease specialist, and I also have a master's in public health services administration from Dr. Torrens. I have two questions. One, I'm a little bit surprised that the state of California is spending less per Medicaid child than 45 other states. Now, I'm originally from the state of Mississippi, and I always thought they spent less on everything. So I'm really kind of surprised and disappointed that the state of California is spending so little money. Does it mean that the kids are less sick? Has people looked at that? Do we have a healthier population of children and they require less care? Or is it just that they can't vote, so they don't have any power? The other question is concerning the coordinated care. You kind of answered the question before I asked it, because I think that is so important, because we're spending so much money now on health care that my question is, how do you get the message to the medical school that we need to be teaching coordinated care as the norm, and that is going to bring down the cost of care, because it's consuming so much of the GNP that we can't continue to go on at the rate that we're going. So I wanted to commend Melinda. Is it Molina?
Molina.
Molina Healthcare. I've heard a lot about you, but I was kind of interested in the history of how you originated, because I hear your name all the time and you seem to be doing the right things, and kind of wonder whether you've been to Cuba and you're following their model of care.
I've been to Cuba.
I know those are a lot of questions, but
And let me try, I should have cut in, but you're Dr. Shirata, you're a pediatric infectious disease, but also a specialist, but also a graduate of the executive program at UCLA.
not the executive program, I just got the master's in
Got the master's, okay,
but
okay,
I was
master's.
Johnson Clinical Scholar.
Okay, but I think the first question was related to medical school second or first?
Well, the first question was related to why we pay so little.
Why we pay, you were shocked, you're from Mississippi and you were shocked, and what, is it because little people can't vote, or is it because they're just little people? First,
Because they are healthier.
Well,
Yeah, or the
actually,
healthier.
I think it's kind of, it's more of a function of what other states were doing, how early we started managed care, Medi-Cal managed care, relative to what other states are doing. If you look at, for a while, it was the case that New York's Medicaid budget was almost twice ours. It just like the spending was so much higher in New York because they didn't have a lot of managed care, and they started out paying their providers more. So what they reimbursed doctors and hospitals for was substantially higher, and they didn't have a lot of the same kind of utilization restrictions. So California's always had a just in general in the private sector even, we have a much higher penetration of managed care. So we started kind of from a lower perspective. So in fact, if we went back to the slide where I was showing the child and then the total, we rank 45th overall, but we only rank 28th relative to children. So we're actually, relative to the mean, we're closer to the mean for kids. We spend actually more than per kid relative to the average than we do total. So we're not doing bad overall in terms of kids relative to how we do overall, if that makes any sense. So we rank 45th overall for all spending across Medicaid. We rank 28th in terms of kids. So it's not the case that we're not I don't think it's related to kids not having a vote or we don't emphasize kids. I think it's just that California started in a managed care environment earlier, and I think that historically has meant that we have tamped down costs more over time, and that the state of California, they're very aggressive purchasers for drugs. They negotiate supplemental rebates, which a lot of states didn't do for a long time. So they've just employed a lot of strategies. So I was using the term miserly, which is kind of value judgment, and and not politically correct. And it might be more neutral to say that they're an extremely efficient state.
I kind of like the miserly reference.
Okay, I'll go back to my.
So a comment about training, because we have these huge training programs, 300 residents and fellows and 350 medical students. So we do spend a lot of time talking about coordinating care and team care and how we look at the utilization of resources. So there's been a lot of research done, and so we introduced this year the very first question our faculty providers are requested to ask a new patient is, are you having trouble making ends meet at home? Because of the correlation between impoverished, worried families and the health conditions of their children. So it's an experiment. We'll let you know how it works out. But then the next call after the clinical conditions addressed is often to a social worker or to one of our other support team members, and we'll see how that works out.
Okay.
I think that's great, because I know I'm a member of the Academy of Pediatrics, and they have now, over the last 3 to 4 years, realized that those social determinants around the children that come into their offices are very important to pick up on, and have recommended similar types of questions when the kids come in to the parents. One of the things I will say, following up on your comments about what California pays, and this is across the board. First of all, we're a victim of our own success, I guess, and I agree with that. The other part of it is when states decide how much they're going to pay you, part of it's developed by the actuaries. You say, we've got this number of benefits that I'm talking about health plans now, are going to have to cover. Therefore, your rate is going to be this. Right now with CCS, that rate is here. If at any point CCS became under the realm of the managed care organizations, then obviously that rate would have to go up. So part of this is by virtue of what the actuaries are computing and what sort of benefits they've included. So that may have a role to what, in terms of what you're talking about.
Now about human health. I'm interested in a little bit of the history. Just give me
Oh, you know what? I'd love to do that, and I will stay here afterwards and give it to you, okay? If you got an hour, I'll give it to you.
It's a long story.
Yeah, but I think in the interest of maybe other people, we should move on to what other questions there may be.
And she's been very patient.
Oh, very patient. I'm Mia Morales, and I'm a MBA candidate at a local university. I will mention for their safety.
And Paul won't mention that Children's is a USC affiliate.
I did earlier.
Oh, right.
But that's the last time I'm going to mention it.
I have a question about a point that Mr. Riviano actually made regarding the uniqueness of children's hospitals and their capacity and willingness to collaborate with others. I think a term that I've heard floating around is competition, which is a mixture of competition and cooperation. I was wondering if you could comment more on the sort of infrastructure in place, specifically with the hospitals in California, freestanding children's hospitals, about sharing information. Is it something as simple as picking up a phone and asking for recommendations from a colleague, or is there something in place where you're able to transfer data and show what quality initiatives are truly working for your population?
And the question is from a USC candidate, which is actually fine, on Bruin campus, not a problem, but directed towards Paul. And in terms of cooperation among the children's hospitals, how do you share information? How do you ask questions? Is there true cooperation among them?
So I'm going to have Ann help me answer the questions, because I do think there is a formal mechanism in place, and it's the association that plays a role. Again, I'll let her comment on the details, but we do have our nurse executives meet on a regular basis. Our government relations executives meet, the CEOs meet, the CFOs meet, and it is an open book. And so there are formal and informal ways I'll give one anecdote and then turn it over to Ann. Earlier this week, our chief strategy officer and I were at Stanford together for half a day, and we were talking about how to share some real interesting and meaningful quality data and some other things that we thought could benefit our respective institutions. So it's real, and it's baked into this process. So I really admire what the association's been able to build.
We do have across sort of executives across our hospitals, we have groups that get together, as Paul said, regularly. The other thing that is going on with children's hospitals that's, I think, very interesting is that we, across the country, have a hospital engagement network called Solutions for Patient Safety. And, the motto of that organization is all teach, all learn, and we don't compete on quality. So, and there's a number of hospitals. It's run actually out of the Ohio Children's Hospital Association, and that's been a very, energizing force amongst our hospitals, and it really is, a no harm, mantra. The other thing in California that I think is really interesting, it is not run by the Children's Hospital Association, but it's actually run by the physicians who work in the various parts of our organization. Our CMQCC, which is the California Maternal Quality Collaborative, something, I'm missing a C somewhere, but and they look at sort of C-section rates and things like that. And there's also a similar organization for NICU stuff. It's not a very technical term, but where the physicians get together and really talk about how can we work on improving quality and outcomes. And that, I think, my perspective on this, I've only been in this role for 2.5 years, but kind of what people have always told me about children's hospitals, or just pediatric care in general, that is kind of different from adult care. And I'm not the most knowledgeable person on this. There are probably people sitting in this audience who are more knowledgeable, but that was always this philosophy sort of dating back to the very early days of treating kids, that because there wasn't a lot of research out there, there was just there's philosophy of cooperation amongst pediatric specialists around how do you treat kids. And I think you get that sense when you're in children's hospitals that there is a lot more desire to collaborate across, that just sort of grew up as part of the culture. And that's my impression of it, at least on the medical side.
I would agree with that, and I'll just use Children's Hospital as a member of the Children's Cancer Group, national group focused on how working together to improve outcomes for these individuals, and it's a wonderful organization, and I think it's a perfect example of what you're talking about, Ann.
And there are many, many others. There's a consortium of children's hospitals that we're a member of that's in genomics and personalized medicine. It's a consortium, and again, these would typically be competitors, and here we are sharing everything. So lots and lots of good examples.
Follow up on that same point. So just real brief. So when I was with Ascension Health, and I'm working in knowledge management and innovation there, we actually had both the quarterly meetings, the CLOs, the CMOs, the CNOs. But then we also had electronic infrastructure for sharing, kind of like basically a LinkedIn or a Facebook type of structure for a community of practice, so that when the docs and nurses are asynchronous, they can still be connected. And I'm wondering, do your collaboratives also have that kind of infrastructure, or is it still more pretty much meeting conference-based?
I am not an expert on how CMQCC or the neonatology piece of that works, but my understanding is it would be more there'd be more electronic interface for that. There's a lot of data collection that goes on in those groups, but otherwise, the groups that we run out of the association tend to be, but I would also say actually Solutions for Patient Safety also, there's a lot of data interchange there. But otherwise, at the trade association level, it's really more meeting-based.
And yes, you've also been very patient.
Hi, my name is Tammy. I'm a recent grad at the school here. My question is, I think we addressed a lot of issues that are facing pediatric care, so low reimbursement, the need to address social determinants of health, and also access to subspecialty care. So where do you see in your role, as a children's hospital, as a health plan, I guess you're speaking more from the government side, but local and state government to kind of collaborate with each other, and who who should be leading kind of the charge to really advocate for all these things that we're addressing today?
And the question is from a recent grad from the school here. And the question is, how can we get all the different constituents to really collaborate and really understand and address the needs that we've brought up tonight? We brought up the needs of access, social determinants, etc. And how can we have that actually happen? Did I say it correctly? Good.
Well, I think there's always a natural tension. So, in my role, I represent the trade association, so we interact a lot with the state. And I think that, as I was mentioning earlier in my presentation, because the state of California is such a large payor, they drive a lot of the policy, they drive a lot of what providers think about and how providers behave. And so there's a natural tension between them as a payer and as policymakers and providers as providers of care. There is a lot of interaction that goes on between that. But I think that there's this kind of higher level conversation that goes on like at the federal government level and federal payers and people talking about the Affordable Care Act and how's that going to get implemented. And then there's sort of how the rubber hits the road as it trickles down both at the state level and then to the local level. And I think kind of the tension is that a lot of times healthcare delivery is local or it's regional depending on what exactly is being provided. And some of that, how that gets worked out, needs to be done at the local community level and kind of involving local stakeholders. But then some of the rules need to be set kind of at the state level. So there's, we do have opportunities right now, for example, as Michael was mentioning, there's a lot of activity going on around the California Children's Services Program because the state wants to put it into managed care. And there's a large group of pediatric stakeholders that are meeting to really deal with that children now, the American Academy of Pediatrics, us, others. So that is an active group, and that group has been meeting regularly. But how that sort of works out is going to depend a little bit at the local level. For example, in LA County, in this region, how healthcare is provided generally is really delegated, right? So you have payers to health plans delegating to medical groups, and then medical groups contracting with physicians. It's really complicated. That's not the same as it is in San Diego. The system is different. The providers are different. So I think there is a need for sort of that state level engagement, but there also has to be really a local engagement because the community level it's different community by community.
Well, I agree. This has been a challenge since I started practicing. How do you balance, the needs against the dollars? Let me just say this, that without the children's hospitals that are in the state of California, we could not function, okay? Because we take care of a lot of kids. And they, as Paul has said, they have very special needs. And this is not just in California, it's around the country. So we have a vested interest in, maintaining the viability and, for these institutions. I think the issue that comes up and the tension comes up is, how do we pay for it? Because again, we're not rate makers. We're rate takers. So that puts, some stress on the relationship. I used to say my kids and I used to have some spirited discussions. And I think that's what I would, characterize this as. They're very important partners for us.
Okay. I'd like to thank our panelists for coming and presenting. It was a wonderful discussion about pediatric healthcare. And I'd like to thank the audience for also asking wonderful questions. And I think we're done.